I will talk about our latest paper with the title Associations of the Delayed Changes in Glutamate Levels and Functional Connectivity with the Immediate Network Effects of S-ketamine. And here we tried to investigate the hyperacute effects of ketamine during infusion on the resting state functional connectivity and magnetic resonance spectroscopy. I will briefly give you an overview about the outline of the talk. So I will quickly talk about the previous observations and our hypothesis. Then I will describe our subjects and the study design, briefly go into our results and interpret them, and then talk a bit about the limitations of the study and the take-home message. So what did we see so far? I know that you're all very familiar with the topic of ketamine, but for understanding the reason of our study, I wanted to briefly go into the MDD brain biotypes. So for individuals with major depressive disorder, previously a hypoglutamatergic state was found. And this means there was a glutamatergic deficit in the prefrontal cortical area and the anterior cingulate cortical area in patients with MDD. And this deficit was correlated with the clinical manifestations as well as the duration of the disease. And while it's not really clear how this hypoglutamatergic state comes about, it was speculated that the ongoing stress in the people leads to or acts on this more vulnerable prefrontal cortical area, which then leads to an increase in extracellular glutamate, which together with the impaired glutamate-glutamine cycling, which you can see here in astrocytes, ultimately leads to neuronal atrophy, and this leads to a decrease in prefrontal glutamatergic transmission at rest. Then another state that was found repeatedly in patients with MDD is a default mode network hyperconnectivity. And the default mode network, as you probably also know, is constituted of the medial prefrontal cortex and the pregenual anterior cingulate cortex, the inferior parietal lobe, and the posterior cingulate cortex. This network is mainly involved in self-referential cognitive processes. So it deals with, for example, mind wandering or daydreaming, as well as autobiographical memory retrieval, for example. And it was suggested that this excessive focus on the emotional state of a person might manifest as depression-related rumination in those patients. So we can see that in MDD, the glutamatergic levels and the DMN resting state connectivity might be trait biomarkers for major depressive disorders. And here we can see that glutamatergic state can be assessed via MR spectroscopy, while the network changes might be assessed with resting state functional magnetic resonance imaging. The region which is highly involved in the psychopathology of depression is the pregenual anterior cingulate. And for this region, there were different effects found. So for example, altered functional deactivation patterns were observed in response to hedonic stimuli. Furthermore, for the neurometabolic side, altered neurometabolic levels were also found in this region, and an elevated pretreatment activity in the PGA-CC at rest was also found to be correlated with a better treatment outcome as a response to, on one hand, traditional antidepressant medication, but also sleep deprivation, transmagnetic stimulation, or ketamine treatment. Then to go a bit into this biphasic mechanism of action, which our group also mainly focuses on. So as you also probably all know, is that ketamine supposedly predominantly acts on GABAergic interneurons, which you can see here. And this ultimately or directly leads to a glutamatergic surge. So to go through this figure on the right, in blue, you can see the ketamine plasma concentration during the infusion, and in green, the therapeutic effects of ketamine. So during infusion, which we call the immediate or directly after infusion acute ketamine effects, we have on the one hand this glutamatergic increase which increases glutamatergic neurotransmission. This leads to an acute disruption of brain network configurations. Also, molecular downstream mechanisms are activated, which mainly lead to BDNF increase that leads to neuroplasticity increases. So this all happens during or directly after infusion. And of course, also the dissociative side effects happen during infusion. Then on the other hand, we have the antidepressant effects, which are considered more delayed ketamine changes, and they peak after 24 hours. And here we mainly have a constitution of brain network reconsolidation. Then to go a bit into the previous delay changes that have been showed. So in our group, in healthy controls, we conducted a study which compared in 2 brain regions, the glutamatergic levels, and we found that the ratio in this case of glutamate to glutamate was significantly increased 24 hours after ketamine, again in this highly important region for the psychopathology of MDD in the PGACC when they compared verum to placebo. What I also can say, which you cannot see in this figure, is that the measurement of 1 hour after ketamine infusion was also conducted, but there was no significant changes in neurometabolite levels. Then what also has been shown is the ketamine-induced decrease of the default mode network connectivity. So this was here in healthy controls, but it was also shown that ketamine decreases this in patients, and this ketamine modulation of the PGACC glutamatergic levels, as well as the ACC resting state functional connectivity, correlated in patients with better treatment outcome. So we concentrated on this biphasic mechanism. So we say the ketamine infusion acutely changes the synaptic transmission, which then induces adaptive neuronal plasticity. And in the delayed effects, it will change the functional reorganization or functional organization of the brain circuits and normalizes this depression-linked dysfunction. So what we aimed with this study is to broaden the time window of observation. So as I previously said, that the studies conducted before by our group, they measured the MR effects of ketamine 1 hour after infusion. So previously for us, it was not possible to administer the infusion during the scanning, which now was possible in our case. So we really assessed during infusion and 24 hours after infusion. And we hoped to use those during infusion measures as a predictor or biomarkers for the 24 hours network reconfiguration, which happened at the antidepressant peak time effect. And here we hypothesized that ketamine will change the functional connectivity mainly within this anterior cingulate cortical network, and that this effect might be correlated with the 24 hours effect on the glutamatergic levels, again in these ACC regions. To briefly show you our study specifications and the study design. Here we conducted the study in 35 healthy male participants. We employed a randomized double-blind placebo-controlled crossover design, and our infusion protocol consisted, so first of all, we gave S-ketamine in a total concentration of 0.33 milligram per kilogram, and we administered it with a 8-minute bolus of 0.11 milligrams per kilogram and a 40-minute maintenance dose of 0.22 milligrams per kilogram body weight. The modalities we assessed was, as I will mainly talk about today, the resting state fMRI, the magnetic resonance spectroscopy, but we also administered questionnaires for the subjective ratings. We obtained blood levels, and we also did some behavioral tasks and EEG measures, which are not part of the current investigation. So to briefly go into a bit of detail about imaging modalities, because I think, or I was told that there will be mainly clinicians present. So magnetic resonance spectroscopy is a very nice non-invasive method which uses ionizing radiation-free analytical methods to investigate metabolic changes in the brain in vivo. And in our case, we investigated glutamate levels, glutamine levels, and the glutamine to glutamate ratio. Then for the resting state functional MRI, this measures temporal correlations of spontaneous bolt signal, which can be measured among spatial distributed regions during the resting state. So it means with complete absence of any task. And this method assumes that regions that correlate in activity, that they form functional networks. Again, we did this in this key region for major depressive disorder, the pregenual anterior cingulate cortex. And here you can see the voxel placement. So this is our MRS voxel, which was placed in the pregenual anterior cingulate area. And it also was used as our resting state fMRI seat. So the region from which we measured the connectivity to all other voxels in the brain. We did all this at a 7 Tesla ultra high field MR scanner. And we did this mainly because it allows for very anatomically specific regional observations, and also, which is a very strong plus point of this ultra high field imaging, it allows for the nice separation of the GLX, which is the combined signal for glutamate and glutamine. So it enabled us to measure glutamate and glutamine separately. Here you can see our study design. So we had 2 study arms, and in the first arm, they received either ketamine or placebo. We put the subject in the scanner, and for baseline measures without any infusion, we measured MRS and MRI. So we acquired glutamatergic measures and the resting state functional connectivity. Then, while the subjects were still in the scanner and not taken out, we started the infusion in the scanner. And we obtained blood levels in the beginning, so around the bolus, and at the end of infusion. And we again repeated the MRS and the MRI measurements. Then after the infusion, so retrospectively, after they came out of the scanner, they answered questionnaires for the subjective ratings of the experience during ketamine. And then 24 hours later, we repeated the MR part of the study. So again, we measured resting state and MRS. After a 3-week washout period, we crossed over the 2 treatment arms, so they received the respective other treatment, and we repeated the whole procedure. Then to show you our results. Here first, I'm showing you the immediate ketamine-induced changes. So what we found is a resting state FC increase of the PGACC to the medial prefrontal cortex and the dorsal medial prefrontal cortex. So during infusion, we found an increase in resting state FC in this, which can be considered anterior default mode network. So PGACC is part of the default mode network, and those regions are as well. So during infusion, we have this within DMN connectivity that increases. For the delayed changes of ketamine, we on one hand see a decrease between this PGACC region to the inferior parietal lobe, which again is a region of the default mode network, and also a decrease between the PGACC and the DLPFC, which is considered a region of the central executive network. So 24 hours after ketamine, we therefore have a decrease of within DMN connectivity and a decrease between nodes of the DMN as well as the central executive network. On the metabolic side, while we did not see any changes acutely during infusion, we did not have any changes in glutamate, glutamine, or the ratio. Here, after 24 hours, we see a significant increase in glutamatergic levels, in glutamate levels, 24 hours after infusion, which can be seen here on the right. So this is always compared to baseline. So everything you saw so far was within the treatment arm, ketamine compared to baseline. And here, 24 hours after ketamine, we find a significant increase in glutamate levels in the PGACC. Then what we were most interested in is the time point correlation of those effects. So we can see here, even though just at trend level, that the immediate changes of the PGACC to DMPFC resting state FC, so this immediate increase in resting state FC was correlated with the delayed change in the PGACC glutamate level, so with the increase in glutamate 24 hours later. Then we did some exploratory analysis also on the baseline predictive character of our modalities. And here on the left, on the one hand, we see the baseline correlation for PGACC to IPL resting state FC, so how strongly those 2 regions were connected at baseline. And this correlated significantly with the delayed change in the same connectivity. So it means the stronger those two regions were connected before the infusion, the bigger the decrease was after ketamine. Then similarly, on the metabolic level, we see here the baseline of the PGAC glutamate level, which again significantly correlated with the change 24 hours later. And here we can see the higher the glutamate, the lower the glutamate level, the higher the change after ketamine infusion. So to briefly explain interpret what this might mean, we here on the one hand see this increase in within DMN connectivity, and this might reflect an increased state of mentalizing or increased neuronal plasticity that might start in this prefrontal cortical area, which was shown several times in animal studies, and that this might serve as an initial disruption of this network functional connectivity that might be dysfunctional in major depressive disorder. Then for the resting state decrease after 24 hours, specifically for the decrease within the DMN, this might reflect the normalization of this observed DMN hyperconnectivity in patients, which followed the antidepressant time course. So it was observable only 24 hours after ketamine infusion. To interpret this glutamatergic increase after 24 hours, again, this might reflect, even though it was in healthy controls, the direction of the change might reflect a glutamatergic deficit that was normalized after ketamine. And this change could even be predicted by the acute resting state FC changes. So what does this correlation mean? So we think that this increase in resting state FC during the infusion that was measured, that this might enable a reconfiguration in this PGACC area 24 hours after infusion, and this might have presented itself with this glutamatergic increase. To quickly talk about the biotypes, which I also introduced in the beginning a bit. Yeah, I was a bit confused on the directions when I explained it, I'm sorry. So when we think about the biotypes, so we have this hypoglutamatergic state in patients. So we saw that the lower the glutamate levels were at baseline, the bigger the modulation. So the higher the increase was 24 hours later. The same we observed with the functional connectivity. So the higher the functional connectivity, so the more hyperconnected the DMN was in our healthy subjects, the more the reduction after ketamine was. So we figured that biotypes that more closely resemble this MDD symptomatic, they might be more responsive to ketamine. So what I can also say about our further acute biomarkers that we obtained. So I told you, or I showed you in the study design, that we obtained blood samples during infusion. Here we used them to measure ketamine as well as ketamine metabolites in the plasma levels. So we measured norketamine and hydroxynorketamine. And with our questionnaires, what we correlated was the dissociative side effects, for which we used 5D-ASC to measure them. And in our data set, at least, there was no significant correlation with either the acute changes or the delayed imaging markers that we acquired. So to briefly talk about limitations and the take-home message. Limitations on one hand, you as clinicians probably saw that our infusion protocol did not directly follow our clinical or the general clinical protocols that are usually used to treat patients. But this was the case because it was specifically designed for our research purpose. So we needed to have a steady state during our imaging acquisition. So we used this bolus to reach this very fast and then maintained it as at a nice steady state for our imaging acquisition. The next thing that is very apparent is the lack of the comparison with MDD group. Here we measured healthy controls based on the previous findings in the literature, or also from our group, which showed that that also the acute and delayed changes were visible at the metabolic level and the functional connectivity level in healthy controls. So we assumed that also their correlation will be visible in healthy controls. And of course, this can only serve as an initial mechanistic investigation. And then another time limitation was the time point of the blood sampling during infusion, which might have been a bit too early. Here we found that the time points we used might be not late enough to achieve comparable plasma levels of ketamine in all participants, and also specifically for the metabolites which we measured, so the norketamine and the hydroxynorketamine, the time point at the end of infusion was not late enough. We measured them because we had the possibility to, but of course it would be more meaningful to measure them a few hours after infusion or even on the next day to get a better conclusion about the plasma level correlation. So as a take-home message, we found that a single S-ketamine infusion can induce a delayed resting state FC decrease in the DMN, which is preceded by an immediate DMN resting state FC increase. And these immediate changes in resting state FC, they were linked to glutamatergic level increases in the PGACC region, and this revealed a cross-modal association between the investigated time points. We furthermore could show that baseline measures, they were correlated with the magnitude of the ketamine-induced changes. So this was the part about the biotypes. Biotypes more closely resembling MDD show more modulation by ketamine in healthy populations. Then the main take-home message is that our study really highlights the complex interplay of network and metabolic activity within the first 24 hours after a single ketamine administration. So with this, I would like to thank everyone in our team who made this study possible, and you for your attention and for having me. Thank you very much.
Great. Thank you very much indeed. That's terrific. I just urge anybody who wants to ask questions to either put them in the chat or put their hands up. So that was really nice and clear. I'm a bit slow when it comes to this sort of thing, so I just wondered if we could go back to the results slides. Do you mind just going back to them and just we've got plenty of time, which is nice, so that we can just go back to this.
This would be the first.
So the resting state functional connectivity increased to start with.
During infusion, we found an increase in the default mode network.
Yeah. Why do you think that was?
So we're not very sure about the directionality, but we might, or we think that this acute increase in glutamate modulated functional connectivity, that the functional networks were disrupted initially by this glutamatergic surge, and this somehow manifested in an increase in functional connectivity, which was not correlated directly with our decrease. So we cannot really say why it increased acutely. We can say that this was predictive of the glutamatergic increase later, but it seems to be not directly connected to what happens 24 hours in the sense of resting state. So this was actually one thing we expected, that whatever happens connectivity-wise in this network is predictive of what happens 24 hours later. But it was not the case, so there's no study which showed this specific case of resting state FC increase in the default mode network, specifically during infusion. But we think that this might kind of reflect this increase in glutamatergic surge and this increase in synaptic plasticity, which mainly happens in this prefrontal cortical area, which was also shown in animals. So somehow all the new synapses and this glutamatergic surge leads to an initial increase in FC in this network.
Okay. And how does that compare with other? I mean, I hope I'm not going to sound like your examiner, but how does that compare with other studies? Is that the same sort of thing that other people have found?
So in general, there was this hyperfrontality shown during ketamine, also during infusion. So there's an increase in prefrontal metabolism, which was shown in PET studies, for example, but also conductivity seems to increase during infusion. So there's a hyperconnection and hypermetabolism, which is shown during infusion, but it was not shown specifically for this network yet. But an increase in metabolism as well as FC is in line with the previous literature on ketamine during infusion.
Thank you. Should we just go to, can we just look at some of the correlations as well? Just go through those again, just a little bit more slowly. But Luke's got a question.
Would be the first.
But we'll go straight to Luke, actually, if that's all right. Luke, do you want to? Yeah.
Yeah, sure. Thank you, Lena. That was a brilliant talk. Such an interesting study. If we go back one slide just to the glutamate, your day one glutamate results. So just to confirm, I want to check. So this is this is a crossover study. So you've got subjects that have a pre, during, and post for both the placebo and the ketamine, yeah?
Exactly.
Exactly. But here we're looking at just the baseline and 24-hour results for just the ketamine arm.
Exactly. This was just the ketamine arm. So we followed the statistical approach of the previous study. So it investigated the changes within the treatment arms. However, in the paper, we also included linear mixed effect models for both modalities. For the resting state, we could confirm most of the findings, but for the metabolites, since the changes were very small and just above detection rate for glutamate. For glutamine, it was below detection rate, which we found out by a power analysis. But for glutamate, since the changes were so small, they were not apparent in the linear mixed effect models. But we did try to, of course, also include the other treatment arm and both time points for both conditions.
Okay, perfect. Yeah, because that was my question, just more about the kind of robustness of this. And also, did you look at order effects at all?
We did look at order effects as well, but we did not find significant changes or significant differences. So we did, however, in our dissociative side effects. So it seems that people who received ketamine the first time, they had significantly higher dissociative side effects compared to the people who expected to get ketamine a second time. But in the sense of imaging markers, we did not see this reflected.
And just one final bit, just looking at that graph, the kind of obvious thing that stands out is what, it's quite a low, outlier in your baseline group. Was that a concern at all, or?
Not really. So the effects did not change when we excluded this participant, but it was a very low glutamatergic participant. That's fine. That's correct.
Perfect. Thank you.
Great, thank you. Could you go on to the next graph? Is there and this was a general comment or question that just occurred to me as you went through, is it possible that the effects you're seeing are due to regression to the mean? So you say that those who I think had higher functional connectivity at baseline had more of a reduction, and same sort of thing happened with the glutamate levels, wasn't it? So those who were lower at the baseline, they had a higher change.
For the baseline correlation, probably this is more the case. We did not use directly the baseline, but we used an adjusted baseline, which tried to take care of this mathematical connection between the change and the baseline. So we hope by using this method, we try to address this problem. But of course, there's always a risk that this is a mathematical issue.
Thank you. And there's a question about there's a sort of methodological question. Why did you use S-ketamine rather than racemic ketamine?
So when we planned the study 6 years ago, I think the main direction was developing in the sense of S-ketamine. Yeah, since we basically here also investigated the NMDA receptor excitability and inhibition. So the plan was also to broaden this to GABAergic modulation. So since we really are interested in the specific receptor modulations, we thought to use a more potent agent. And yeah, the literature was accumulating in the S-ketamine direction. So we went with the time 6 years ago. So we also investigated S-ketamine in this case.
I'm really keen to try and stimulate others to ask questions. But which instrument did you use for measuring dissociation? Because sometimes they're rather broad. I mean, the CADS, for example, has a variety of items that are not particularly relevant to ketamine in a way. And I'm wondering if you did any item correlation as well.
So we did use the CADS as well as the 5D-ASC, but the CADS was more.
Sorry, what was the second one?
The 5D-ASC, so the 5-dimensional altered states of consciousness questionnaire. It's a 96-item self-rated questionnaire, while the CADSS is the clinician applied one. So the problem with the CADS 6 years ago was that there was no German version. So we did use the CADS, but just for us to compare it with the previous literature, but we did not publish it, since it was not validated in German yet, and our participants are exclusively native Germans. Therefore, we used the 5D-ASC, and we also did item correlation, which we actually publish in our next paper. So it will be exclusively focusing on mainly focusing on the disembodiment and the experience of unity, which can be grouped in this questionnaire. But for this investigation, we did not exclude specific items or did item correlation to exclude non-dissociative effects, while the 5D-ASC is pretty specific on dissociation.
That's quite a teaser, isn't it? You're not going to tell us anything. Are you going to tell us anything? Or are you going to wait for it to be published?
It's already published as a preprint, actually. So
so you can tell us
not a secret. Yeah, but in this study, we investigated cortical thickness as a brain morphological predictor of the dissociative effects, and we found that the PCC, which is a region very involved in bodily self-perception, is actually correlating with the dissociative effects in this disembodiment part of the questionnaire. So we do see
structural thickness.
The structural thickness, exactly. So people who have a lower cortical thickness in this PCC region, they tend to be more susceptible for ketamine-induced dissociation.
That's on bioRxiv, is it?
In Psych Archives. Yeah.
Thank you.
Sure.
So I have a couple of questions, if you don't mind. Lena, was a terrific talk. When you presented the immediate result, was that like basically the time you're considering is at the end of the infusion, so at the end of the steady state?
So, sorry.
Is that correct? Or?
The immediate state was really during infusion. So our measurement, we were most interested in the imaging modalities was the resting state, because for the resting state, there had been shown modulations on network level, while on the metabolic level, there was almost nothing in the literature which showed those very subtle transient changes measured by MRS. So for us, the priority was the resting state, and both modalities were really measured during infusion. So we gave the bolus over 8 minutes, then we had a 2 minutes break after the bolus to see, because the participants were inside the scanner, to see if they really tolerated well. We briefly talked to them if everything was fine, and then we continued with the maintenance. But the maintenance over 40 minutes really was the time during which we measured. So we had this first the MRS, which was around 25 minutes, and then we had the last 10 to 15 minutes resting state. So it was all happening at the steady state. So after the bolus, we directly, or almost directly reached the steady state, which we then maintained for the whole imaging acquisition.
And you did the level of the ketamine metabolites at which point? At the end, I assume, of the scanning session?
Yes. So we had 3 time points of blood taking inside the scanner after 8 minutes when the bolus was finished. Then after 13 minutes, when we had this initial dip after we stopped the bolus but started the maintenance dose, and then at the very end of the infusion. Yeah, but at the first time points, it was not very comparable between subjects yet. At the end of infusion, it was rather comparable for ketamine itself. But as I said, for the metabolites, it was too early to obtain very reasonable measures, because for a lot of people, it was still below detection rate.
And did you have a specific reason for, so the overall dose, if I read correctly, was like a 0.33 milligram per kilogram? Was there any specific reason to use that dose instead of like using the same protocol by reaching the 0.5 milligram per kilogram?
So for 0.5, this is applied for the racemic form. So often it's then reduced by 2 for S-ketamine for 0.25. But in our case, we calculated our steady state for the dose we wanted to reach for the modulation dose, also to show the dissociative effects, but have clinical relevance still. And in our 3-compartment measurement, we ended up with this dose being most applicable to our study design.
Right. And just like a clinical question, how overall was tolerated, the procedures? Did you have anybody who was not able to tolerate it or have to stop the scan? Or
actually, everyone tolerated it. So we didn't have a single participant who stopped the measurement. So I think this was also, it seems a bit weird to have this 2-minute break, but it was very beneficial for us, because we really could make sure that the participant felt secure, and the doctor was always around. So we had constant contact if needed. So nobody said they felt uncomfortable. So they all went through with the measurement, and actually everyone gave positive feedback about the experience, while one participant said he would not do it again, but it was the only person, and even he followed through with the infusion in the scanner. I mean, it's difficult to measure inside the scanner. Even 7T is a bit more narrow than lower field strength scanners. So it was not guaranteed that everyone will tolerate it well inside the scanner.
Thank you.
I can jump in again quickly if no one else is asking anything. With your spectroscopy you got during the infusion from the pre-general, I think in the paper it says you weren't expecting any changes, or in the discussion. Is there any reason for that, or why you think you did or didn't?
So we didn't expect them because they are very transient and probably too low to detect. So just based on which range of change is expected, we thought can not be measured in our acquisition, but also we based it mainly on previous studies which acquired MRS during infusion and did not show modulations during infusion, but either directly after or the day after. So it was based on previous literature, and it proved to be the case for our study as well.
So I've just recently finished collection for a similar-ish sort of study, but with crossover design in patients with depression, getting the ketamine infusion in the scanner, but we're blocking it with naltrexone. But we've collected spectroscopy throughout the first half hour of the infusion, so kind of dynamically, and we're able to kind of look at it blocks.
Okay, that's
so
very exciting.
We're tidying up the analysis on that, so we might have something to share with that soon.
That's very cool. Yeah. So I said that our acquisition was 25 minutes, but actually we measured 3 boxes. So for other research questions, we also examined the AMCC, the anterior mid-cingulate cortex, as well as the dorsal PCC. So therefore, we cannot make it dynamically in the PGACC, unfortunately, but we do have 2 other regions which were not subject of this investigation.
Very good. Thank you.
Can I ask why you chose a crossover rather than like a parallel design between the groups?
Actually, we, as I said, we followed a very similar study that was conducted by our group, and we wanted to broaden to investigate the time window just by changing the time point from 1 hour after infusion to during infusion. So we did not want to change the design as well. So whatever we find might be at least comparable statistic wise. So that's the main reason for sticking to the crossover design.
You said just before we started that your group is repeating this study in people with depression. Is that right?
It will not be the same study. It will be a similar study which does not measure during infusion, but it measures the day before infusion and after infusion, as well as after 2 weeks of infusions. But it will focus on the blood biomarkers and the predictive biomarkers in the brain. So it will not assess the time point correlation of during infusion and the 24 hours assessment, rather than the really clinical predictive power of different blood biomarkers and imaging.
And that's using 6 infusions, I think you said.
Yes, exactly.
Yeah. That must make it very complicated if you've got, you've got sort of things going up and down. So, but presumably you just take it, during the first infusion and then after the 6th, that sort of thing?
So before and after the first, to have this baseline measurement, and then still the time point of the maximum antidepressant effect for the first time, and then after the last infusion.
Right.